A 52-year-old lady was referred to us with complaints of upper abdominal pain, and she underwent some routine investigation including ultrasound and CT scan. There was a suspicious lesion somewhere in the body of pancreas, and you can see a classical STEC sign here, the bile duct, the pancreatic duct in the head of the pancreas region. This almost rules out a complete pancreas divisum. It's mandatory that whenever there is a suspicious mass lesion anywhere in the pancreas, you start the evaluation from the head. We always make sure that we rule out any gallbladder stones, and then we go ahead to the target area, that is the pancreatic genu, body and tail of pancreas. Now, very careful evaluation of pancreas is necessary, especially when we are suspecting small tumors in pancreas, and we all know that EUS is perhaps one of the superior modalities of imaging for smaller lesion, especially less than 1 centimeter. You can see the pancreatic duct running in the pancreas. So this was one of the reasons why patient was asked to undergo an endoscopic ultrasound to evaluate what is the relationship with the duct and what exactly is the lesion. So as you can see here, the lesion is not so obvious initially, and then we scan into 12 megahertz, and then you see this hypoechoic lesion in the pancreatic body region measuring around 2 by 1.2 centimeters. We don't see any dilatation of the pancreatic duct in the body or the tail, which indirectly suggests that it's not a lesion which is occluding the duct as of now. A careful evaluation of this kind of lesion is mandatory. Most important thing which I would like to share with our aspiring endosonographers, that always stay put at the target or organ and just make some fine changes or adjustments in your scope movement in terms of to and fro movement, a little bit of torque or anti-clock or clockwise, and a little bit of up and down position. You'll be able to see such inconspicuous isoechoic lesions such as this on this radial echoendoscopy. We wanted to make sure the duct is not involved or infiltrated or leading to dilatation in the tail. Therefore, we are having a repeat evaluation of the tail. We all know that when you suspect neuroendocrine tumors of pancreas, we need to rule out if there are any associated liver lesions, small ones which can be missed on conventional imaging. So we are seeing the left lobe of liver here, and then we come back again to the pancreas, evaluate the mediastinum, rule out any lymph nodes, and then we proceeded with a linear echoendoscopy. So now linear echoendoscopy, you can see very well irregular hypoechoic lesion in the body of pancreas. As I mentioned several times, that the target lesion has to be placed between 5 o'clock and 7 o'clock position on the screen, just below the transducer. And with a simple jab, we went into the lesion. We prefer to use smaller needles, as I mentioned in pancreatic lesion, and very, very gentle withdrawal of the needle and very gentle advancement again. So we have gone deep into the hypoechoic lesion, and then we start aspirating, and the final aspiration did show this to be a small neuroendocrine tumor. Now we can debate whether this FNA should be done, but this was purely done on the insistence of the patient and the referring clinician.